Good afternoon, everybody, and welcome to Nottingham City ICP Share and Learn. We're sorry that we're a few minutes late to opening this session. We've just had a few technical issues, but we're here now. So I'm delighted this afternoon to welcome Dr. Julie Hankin, who's the Medical Director from Nottinghamshire Healthcare Foundation Trust. And I'm also joined by Rich Brady, Programme Director of Nottingham City ICP. And I'm Tracy Tyrrell, Deputy Clinical Lead for the ICP. We're going to follow a usual format, which is Julie will present to us and then we'll have 10 minutes for questions and answers. So please do start to post your questions or any thoughts and reflections into the question bar. All right, so I'm delighted now to hand over to Julie.
Thanks, Tracy. Hopefully everyone can hear me okay and see the slides. So apologies, they were completely my technical problems that caused the delay. Hopefully this won't play into the presentation itself. So what I was going to do is run through an overview of mental health services. I realise this is an ICP on the actually partly mental health makes sense at that scale, but also a lot of the transformation work and other things that are happening are all being done ICS wide. So I think just to start off with, just to really emphasise, in terms of who provides mental health services, we all do. We all see patients every day who have mental health difficulties, whether or not that's what they've presented to us with. So whether it's primary care, social services, ourselves at the Mental Health Trust with the dedicated services, city care, acute, voluntary, police and ambulance, all of us are dealing every day with mental health. And I think that's a really important thing because historically it's tended to be assumed that it's only the mental health services who are going to think about what we need to do, and we need to work very differently going forward. But having said that, just to think about the overall population context for mental health patients then. So we know that one of the key problems is that we still have a massive life expectancy gap between the majority population and then people who are users of specialist mental health services. So you will die 17 years earlier on average if you're a man and 15 years earlier as a woman compared to the rest of the population. We know that 7% of the population on the whole are in touch with us, but, and this is for Nottingham, 19% of A&E attendances and 26% of non-elective admissions end up being around mental health. And 1 in 4 people will be affected by mental health problems in any year, with 250,000 plus experiencing mental illness over their lifetime. And increasingly the evidence is growing in terms of the impact of adverse childhood experience, which leads to almost certain mental health problems later in life. And this is a really important slide for me, and it comes back to that who's seeing which patients. So this is just looking at the comorbidity. If you look at the illnesses like coronary heart disease, diabetes, COPD, cancer down on the left, and then across to the things that are comorbid, the size of the circle shows the incidence of that. And it's very clear that all of those conditions link usually with depression, with anxiety, with pain, and that combination will predict poorer outcomes for those patients and links to deprivation. So this is a huge problem that is actually much wider than what we tend to think of as mental health. And this is just a different way of thinking about it, that we're very used to thinking about that group up on the top left with their first episode of psychosis, but we don't tend to think about that large group in the middle in terms of long-term conditions and mixed physical and mental health issues. Again, just thinking about the ICS context for mental health, we have a fair amount of data now in terms of how many patients we're seeing and a steady increase in terms of the prevalence of depression, as you can see from that top left. And no doubt that it does link into those deprivation indices, which again becomes particularly important for the city ICP. So just thinking about Nottinghamshire Healthcare, we are the specialist mental health providers within the ICS. It's a large trust. It doesn't just provide mental health, it provides mental health and community services, and a large chunk of specialist forensic services, almost 9,000 staff, 1,000 beds, and working out of a lot of locations. And who would we see within our mental health services? So on the whole, within specialists, we tend to see the moderate to severe mental illness. And the illnesses we would tend to be managing would be things like anxiety, depression, obsessive compulsive disorder, bipolar, psychosis. Adjustment disorders are reactions to events, so an extreme distress and inability to cope on top of being bereaved, losing your job, often all of these things happening at the same time. That's not necessarily a long-term illness in the same way as the others, but we call this an adjustment disorder. Somatoform disorders are mental health illnesses that present as physical disorders. So somebody who may present with physical symptoms that just don't quite match up with anything, but individuals tend to be very clear they don't believe these are mental health illnesses, and can often get caught up in lots of tests and procedures that may not be good for them. And then personality disorder and trauma as well. Just picking out one of those, I'm not going to go through all of them, but just thinking about the amount that depression actually impacts on people. So we know that the prevalence is between 30 and 40 people per 1,000. And we know that that is increasing. 65% of working age adults with depression are in contact with services, and they cost the country a lot. And it's easy to put it in those costs, but then to start thinking about just what that feels like for the person actually having lost employment, having lost other elements of their life through depression. So just thinking about how that then plays out in terms of what the services themselves look like, we separate our services through the age ranges, although increasingly there's a move towards trying to think about mental health across the whole age, rather than in these separate groups. But for the moment we have children and young people's services, which people tend to know as CAMS, child and adolescent mental health services. So that involves school liaison, community, but also increasingly crisis team work and liaison in acute services. Inpatient services and eating disorders are a major specialty. In terms of adults, we have IAPT, which is the psychological services in primary care, but also the core of our service tends to be our local community teams, the local mental health teams, who will see individuals and treat for periods of up to 4 to 5 years often. Crisis and home treatment teams. We have a street triage team which works with the police and has a car which is joint staffed by police and CPNs, trying to manage real immediate intervention in incidents. We have an early intervention team which works into psychosis. There's really good evidence that the earlier you can intervene and treat psychosis, the better the outcome, particularly in a younger individual. So they tend to work particularly in late teens and early 20s individuals. We have inpatient units, both acute and rehabilitation. Liaison psychiatry, which works in the acute settings in combination with acute and we have a number of secure settings. There's where we have community teams, day services and liaison. And that just gives an idea of the spread. And it's fairly obvious once you start to look at a map that our services are not geographically dispersed to where individuals may need them, which is a distinct issue as we go forward as an ICS. Apologies, that is an old slide. It's still talking about CCGs. And we have our inpatient services, and this sets out where those are. Again, very much a Nottingham and Mansfield base in terms of the inpatients. the clinical model overall is about trying to work in these 3 different areas and trying to move far more towards the left-hand side of that self-care and prevention and people being able to manage their own health. We're then focused on community and integrated care and really focusing on highly specialist and inpatient care only when absolutely needed, but that it should be absolutely right and expert when it is needed. And then in terms of the ICP's profile and the ICS, we know we have 1.1 million as an ICS that then we're trying to manage this within. We did create an ICS-wide mental health strategy back in 2019, and I led that piece of work with support from the ICS, setting out how would we try to work across the system. And there were a lot of issues we were trying to address through that. So people did not feel that the services met their needs. They were fragmented. We knew that access was not easy and that our contacts with the crisis team in particular were lower than we would want them to be. And I won't go through this patient story in detail, but it sets out something that I think a lot of people would recognise, this constant referrals to different teams, being bounced back, being moved from place to place, and a long time to get to a service that actually met the need. This is just looking at deprivation. Again, this does link particularly to Greater Nottingham and the City ICP. And just to make the point, this is the areas of deprivation in the area, but this is where our intensity of mental health teamwork has been historically. And I think the issue is really these do not overlay. You would expect to be seeing a similarity in that picture that isn't there, and that's largely because of historical issues about how we work. But we wanted to address that and move to a much more whole system approach, really focusing on no wrong door and prevention, bringing mental health and social care together. And there were some core principles, so people may have heard the phrase parity of esteem. This really is about bringing mental health much more into the thinking and thinking of people's physical health and mental health at equal importance and together in a more holistic system thinking, patient driven and prevention focused, but able to get to acute care very rapidly. And we set out 5 strategic pillars that we felt were going to help us to achieve that, and a set of outcomes that we wanted to achieve, particularly starting to narrow the gap in that life expectancy, but also focusing in on things like depression and anxiety, where we know we have treatments that work, but we're not convinced we deliver them in the way that we would want to. That's all moved on quite a bit since we did that work in 2019, and what I just wanted to finish with was just giving you a feel of some of the current transformation work. So we have a huge amount going on across our adult community services in particular, which I'm going to talk about in more detail, but also a lot of work in terms of suicide prevention. The Sherwood Oaks work is in Mid-Notts, is actually completely setting up a new adult mental health specialist hospital and rebuilding our facility at Kingsmill to be an older adults specialist facility, but also the work around moving increasingly to having mental health workers and health improvement workers in primary care. So we have the long-term plan for mental health, and by 2023-24 there are a number of extremely ambitious transformation programs that have to be delivered. These have come with new investment, which is slightly unusual for mental health, but very welcome. And that does bring a lot into the area. Just thinking particularly about the community mental health services, because these are the ones that historically have tended to be a little bit neglected, but actually when the community mental health services are not right, that's when we see blocks in acute, in ED, in primary care and all those other places. So this is a focus on redesigning our teams in and around primary care networks, and particularly making sure that that access is lifted, but also a focus on their physical health and employment through that. So this builds on what we set out in that mental health strategy, and we've been working with PCNs to think about how we deliver it. And again, core principles around not bouncing people between different areas, strengths-based, individual-based, but also starting to work much more as virtual teams in PCNs rather than a focus on which organisation it is, and named key workers and integrated pathways. And this is how it's been set out graphically, starting to think about that idea of how do we bring everything in under the one roof so that it's easy for people, rather than, particularly I find people with complex mental health and physical health problems, it's rarely easy to separate out their needs into nice separate boxes to go to different areas. How do we actually bring what they need to them? And that's what this diagram just tries to pull together, that idea of actually wrapping our specialist services around the core PCN services. And a really crucial point of that is the new work that's happened around the crisis sanctuaries, and that's being delivered in partnership with Mind and Turning Point, and particularly pathways around personality disorder and social prescribing. And this is the expectation in terms of access, that by 23-24 we should be looking at significantly more people able to access these pathways, at least 7,000 in the predicted trajectory. And as part of that then an increase in workforce, and looking at very different skills in that workforce, so specialists, pharmacists, peer mentors, practitioners, as well as our more traditional nurses, doctors, psychologists. So that was a real whistle-stop tour of
Thanks, Julie.
Of a lot of things. I'm very happy to pick up any questions.
Yeah, so thank you. We've got the first question, so obviously a great presentation and very interesting. But in terms of staff out there, wider staff, are you able to help us with providing any information regarding support programs for staff across the system who may not be specialists? And you obviously talked about this in your presentation. So are you able to tell us a little bit about that?
So it was certainly one of the core things that we identified through the mental health strategy work as the ICS, this idea of how did we get to a core level of literacy for all people working in the system. The area that we've been particularly focusing on initially is around that suicide prevention support, and a large part of the money that has been accessed and drawn down from transformation funds will be about developing that ICS education and support package out to individuals focused on suicide prevention, and hopefully there should be far more detail about that starting to come out from that team very rapidly.
That's great, thanks Julie. In terms of aspiration then for Nottingham City ICP from a mental health perspective, what would you hope to see within the next 12 months as those key priorities that as an ICP we should work on?
So I think what's already making a huge difference, and we would have seen more of, I think, without COVID, but will continue to move, is the huge difference in the crisis team provision. So historically, although a large team, it actually wasn't at the level that would meet core fidelity standards for crisis services in mental health. And that impacted then on what we saw in terms of out of area presentations, number of people in ED. That's now fully addressed, and the team is just completing its recruitment up to exactly where it should be, and that's meaning that they're working very, very differently. So it should be much easier for people to access services rapidly, not ending up having to go through multiple areas first. And we are seeing the impact of that then onto a huge decrease in admissions overall. So if I look back 2 years, we were looking at about 50 people receiving care, inpatient services elsewhere in the country on any one day. The majority of those were from Nottingham City. So that's always been where we've seen that flow from. At the moment, we had got down to none just before we moved into COVID. We know we have had to, but we can link any out of areas now to the times when we've literally had to close our own inpatient units because of outbreaks. So we're expecting to see that continued impact. I think the new focus on health inequalities and prevention work, particularly for the city, is going to be crucial, because we know that's where we're sitting on some of those really key issues around deprivation and BAME population groups. But I think for me, the most exciting bit, as I said, is this community transformation. But we've tended to focus so much on all of the acute, exciting front door stuff and not said the reason people are needing that is because we're not able to deliver what they need as a continuing intervention, and thinking of mental health as a long-term condition. This builds and boosts those community teams and puts the skills there. That means we can then link very differently with the GP surgeries and PCNs, and I think that's what will change things hugely over the next few years.
That's great, Julie. And I think that takes us probably nicely into our next question, which is for both you and Rich. But in your views, what simple things can the primary care networks do to help promote better integration? So do you want to go first, Julie, and then we'll gather Rich's views as well?
So I think from my point of view, I think it's about us all moving to learning a new way of working, to thinking of ourselves as one team and one service. And I think that's been something I've seen as a real strength of Nottingham over the last year, 2 years, as I think we now do that in a very different way, and being able to really focus on our patients and populations and what do we need to do and just getting on with it. So I think probably initially it's about building those relationships and conversations and us taking advantage of things like the chance mental health workers and others to say, how do we use this in a way that moves the whole system? For me, we'll have achieved that when we stop endlessly referring to each other and having these transitions between services when there's a problem and the service moves to wrap around, and we don't go backwards and forwards between referral meetings and bounced letters and all of that.
Thanks, Julie. And what about you, Rich, as Programme Director for the ICP?
I'm not sure I could have said it much better than Julie, to be honest, but I'll try and add some additional thoughts. And I think, you know, as Julie said about the one team is the really important thing about primary care networks, and we've sort of set those up. Do primary care networks mean anything to people living in Nottingham? Probably not, but they do mean things to us in the way in which we organise our services. And so the important thing is that, you know, I guess for people working within primary care networks is about understanding who your partners are. And, you know, as I say, that Julie's talked about having that kind of wraparound support, and that comes from us understanding what's around, what kind of assets we've got within our primary care networks or neighbourhoods, however we want to define it. So understanding what's available and what's around within neighbourhoods is really important. But I do think there's a role for us as organisations to make that a lot easier for people working within primary care networks, because I'm not necessarily sure we do. And as I said, PCNs might not mean anything to people living within them, but they do to the organisations that provide the services. And that's important because we all need to be talking about the same kind of areas in order for us to be able to work together. And it's quite probable that we already have the resource available within the primary care networks. We're just not necessarily facing one another. And that's a big priority for us as a city ICP over the next year, work that Tracy's leading, in fact, which is about how we get the assets that we've already got within our primary care networks to work much sort of closer together. So there'll be lots of work happening, especially over the sort of next 6 to 12 months, about how we hopefully as ICP partners will make that easier for people working in primary care networks.
Thanks both. So we're about on time. Our last question is more of a comment, but just to wish Julie, obviously, you know, all best wishes for your future, Julie. We know you're leaving Nottingham, but just the comment, and I know we all echo this, just to thank you for all of your work, both in the city and wider in Nottinghamshire. It's been amazing, so thank you. And a huge thank you for you today, Julie. So thank you everybody for joining.